Today, I will talk about percutaneous mitral valve interventions, the current indications and techniques. When we are talking about percutaneous mitral valve interventions, we are talking about intervention in case of mitral stenosis and interventions in case of mitral regurgitations. I will go through intervention of mitral stenosis rapidly, but I will explain intervention of mitral regurgitation more thoroughly and will take some time. I will give you some history about the mitral stenosis intervention. That's before 1984, when Inouye et al. First described the clinical application of percutaneous mitral valvuloplasty, surgical mitral commissurotomy was a preferred option and was a standard technique for patients who had severe mitral stenosis. Since the introduction, percutaneous mitral commissurotomy has demonstrated good immediate and midterm results and has replaced surgical mitral commissurotomy as the preferred treatment of rheumatic mitral stenosis in appropriate candidates. In candidates who are appropriate for balloon mitral valvuloplasty, now the percutaneous mitral commissurotomy is a standard of care and the treatment of choice in such patients. In 1986, the first double balloon Inouye was a single balloon technique, and this was in 1984, and in 1986, first double balloon performed in adults with calcified mitral stenosis. A very important point you have to know about the transeptal puncture in patients you are going to do a balloon dilatation, balloon angioplasty. The site of the puncture differs between double balloon and single balloon. In case of Inouye, which is a single balloon technique, the site of puncture should be a little higher in the fossa ovalis to allow the manipulation of the balloon to enter the left ventricle. In case of double balloon technique, it is important to be lower in the fossa ovalis, to be close to the mitral valve. This is video on the left, show you how to perform the transeptal puncture. It's very important to do the puncture in two projections, at least two projections. The lateral projection as seen on the left side and the posterior-anterior projection as seen in the right side, and you see the pigtail caster in the aorta is taken as a landmark to be away from this aorta, and in the lateral view, the Mullen sheath and broken bra needle is directed posteriorly towards the left atrium. And this is video showing when after crossing the transeptal to the left atrium. And this is the old one, the double balloon technique. We have to put two wires in the left ventricle, and over these two wires we have to pass the two balloons and do the balloon dilatation as we see in this video. Fortunate enough, now we have the multi-track double balloon valvuloplasty that's developed in 1995. This system, one of the balloon is a rapid exchange balloon, while the other has a conventional design enabling both to be aligned in the mitral valve orifice over a single guide wire. So we need only one wire instead of two wires, and both balloons can go over this single wire, and you can do the balloon valvuloplasty over this single wire. And this video shows you how this multi-track goes over the single wire and the opening of the commissures of the mitral valve. It's very clear here, positioning of the balloons and splitting of the commissures of the mitral valve. The anteromedial and posterolateral commissures are very clear here, that's opened and splitted by this double balloon over a single wire. The second technique we use is the Inouye, which is a single balloon. And as you see in this video, we have the pre-shaped wire coming with the system of the Inouye balloon, and over this pre-shaped wire, this after transeptal puncture, and as we said before, Transeptal puncture in inoe should be a little higher in the fossa ovalis, and you pass the wire, and over the wire, this is the transeptal dilator. Also, it comes with the system of the inoe, and you have to dilate the system to allow the balloon to pass over the wire into the left atrium. Then you direct the balloon to the left ventricle, and this shows you how the balloon split the commissures of the mitral valve. It is a fantastic balloon. It's unique in its characteristics because as you see, inflation of the distal part of the balloon, then you pull it back to be straddling the mitral valve, then inflation of the proximal part, and the last portion to be inflated is the middle part, which is the waist that opens the mitral commissures, both anteromedial and anterolateral commissures. And it's very clear here that you inflate first the distal part, you pull it back till you feel some resistance, that's you are across the mitral valve, then you inflate the proximal part, and lastly the mid part that split the commissures of the mitral valve. The most important part of my presentation today is the mitral regurgitation. Mitral regurgitation, which is new for us, and we have new techniques. Balloon valvuloplasty started in 1984. Now we have an intervention for mitral regurgitation, either mitral regurgitation repair or even replacement for the mitral valve. And you have to know that mitral regurgitation is the commonest valvular abnormalities encountered among adult patients. And the cause of this mitral regurgitation is either primary. Primary means something in the valve. The valve itself is diseased. Or secondary mitral regurgitation, for example, dilatation of the left ventricle leading to annular dilatation. It's very important before deciding or before going to intervention in a mitral regurgitation to identify the etiology of this mitral regurgitation. Now we have transcatheter mitral valve repair, which is a minimally invasive technique. In selected patients, we will show you the patient selection and the indications of this repair after that. So percutaneous mitral valve replacement and its role in degenerative mitral regurgitation and functional mitral regurgitation. And as we said before, that degenerative mitral valve, or what we call primary mitral regurgitation, something in the valve. This physical valve abnormalities in the leaflet or the chordae. For example, the connective tissue disorders that affect the mitral valve, rheumatic heart disease that affect the mitral valve, congenital heart disease, or mitral valve prolapse with flail leaflets. Functional, again, it is due to annular dilatation leading to functional regurgitation due to incomplete coaptation of the valve leaflets, anterior leaflets and posterior leaflets, and this can occur in patients with ischemic heart disease after myocardial infarction, or in dilated cardiomyopathy or non-ischemic cardiomyopathy. You have to know by heart the anatomy of the mitral valve. This is the base for mitral intervention in case of mitral regurgitation. Mitral valve apparatus consists of leaflets, anterior and posterior leaflet, chordae tendineae, papillary muscle, the mitral annulus, and the left ventricular myocardium, the site of insertion of the papillary muscle. And this is a very important figure. You have to know it also by heart. And this is the anatomy of the mitral valve. And you have to know the mitral annulus, the shape of the mitral annulus, which is a saddle shape or a D-shaped, that the flat part of this D-shaped mitral annulus is towards the aortic valve. This is what we call the aortomitral curtain. And the mitral valve leaflet itself consists of an anterior leaflet and posterior leaflet. The posterior leaflet has longer insertion on the annulus than the anterior leaflet, as we see in this figure. And each leaflet is divided into 3 segments. Also, it's very important to know it by heart. The anterior leaflet consists of segments A1, A2, A3, and the posterior leaflet consists of 3 segments B1, B2, B3, and this is very important to know the etiology of the mitral regurg and the direction of jet of mitral regurg through these segments for justification of mitral valve repair. Also, this figure shows the normal anatomy or the normal valve closure, and on the left, the second one on the left is a primary mitral regurgitation due to valve prolapse. Primary means something in the valve, as we said, or degenerative mitral disease. Again, a mitral regurgitation due to flail leaflets, due to, again, some degenerative process in the mitral leaflets. And the third showing an annular dilatation as a cause of mitral regurgitation, and this is what we call functional mitral regurgitation or secondary mitral regurgitation. What is the rationale behind doing percutaneous valve intervention in mitral regurgitation? All of us know that mitral regurgitation, the best treatment option is surgical mitral valve repair or replacement. So what is the rationale behind doing percutaneous valve intervention in mitral regurgitation? Number one, mitral regurgitation is frequent and carries a poor prognosis. In a patient with mitral regurgitation, all of us know the natural history of this disease: left ventricular remodeling, left ventricular dilatation, heart failure, and will end with death of the patients. Patients are often elderly with several comorbidities, making surgery carries a very high risk, or sometimes it's prohibitive in a patient who have a lot of comorbid conditions and elderly. Surgery may be high risk or even contraindicated, as I said before, or prohibitive in some patients who have severe mitral regurgitation requiring either repair or replacement. That's why in this condition, percutaneous intervention will be the treatment of choice in such patients. In practice, many patients are denied surgery, so they are declined by the surgeons. The surgeons refuse to do intervention in some patients due to the presence of many contraindications for surgery. This is the transcatheter mitral valve milestones, like a history. It's actually started in 1999. This was the first transcatheter mitral valve repair in animals, animal study. In 2003, this is the first in human transcatheter mitral valve repair using the MitraClip. And in 2008, the first CE approval of this transcatheter mitral valve repair. In 2012, the first in human transcatheter mitral valve replacement. And in 2013, the FDA approval for the transcatheter mitral valve repair. So CE in 2008, FDA in 2013 as regard mitral valve repair. Let's go to this very important subject, which is a transcatheter mitral valve repair. Transcatheter mitral valve repair is growing, and I think it will be one of the gold standard treatment in patients with severe mitral regurgitation who are prohibitive for surgery or who are considered high-risk patients for surgery. And again, this is the evolution of percutaneous edge-to-edge mitral valve repair. Again, in 2003, the first case. In 2008 was the CE approval, and in 2011, the Everest 2 trial. I will talk about this trial. This is a very important trial, the Everest 2 trial. And in 2013, we have the Everest high-risk registry, after which the FDA approved the use of this technique as a first mitral repair. In 2018, updated version of this MitraClip, the NTR and XTR, and I will talk about this later on, based on the COAPT trial. I will explain also this COAPT trial rapidly. And in 2019, the FDA approval for secondary mitral regurg. It's approved for primary mitral regurg and primary mitral regurg, then for secondary mitral regurg. This is transcatheter mitral valve repair. Rapidly, the idea behind this, actually, you are changing the one orifice of mitral valve into a double orifice, like what Alfieri done surgically. This is exactly like Alfieri technique, which is done through a surgical approach. The use of suture to convert a regurgitant mitral orifice into a competent double orifice valve decrease or eliminated regurgitation. Very important as regard the mitral repair to know the indications and the patient selection or the patient suitable for this repair. Most of the indications of this approach are derived from the inclusion criteria for the Everest trial. It is very important for those who want to have a program for mitral valve repair in their centers and in their hospitals to know how to select the patients for this procedure. We have a clinical criteria and we have anatomical criteria. To understand this patient selection, we ought to better understand staging of mitral regurg and its relation to mitral regurg severity. That's why it's very important to stage this patient into stage A and B, stage C and D. Stage A and B means mild, moderate mitral regurgitation, and these patients, what they need, just follow up and monitoring. For stage C and D, stage C, those asymptomatic severe mitral regurgitation, and stage D, symptomatic severe mitral regurgitation. And stage C is further classified into C1 and C2 based on left ventricular ejection fraction and left ventricular end systolic volume. So if we have an ejection fraction of more than 60 and left ventricular end systolic volume of less than 40, this is C1. And if we have an ejection fraction of less than 60 and end systolic volume of more than 40, this is C2. This is an important clinical criteria you have to know about your patients that is prepared for this repair. What about the anatomical criteria? Very important. These anatomical criteria, you got this criteria or you get this criteria through the transesophageal echo. This criteria includes the following, and you have to stick to all of this. Number one, there should not be any mitral stenosis. So by planimetry, the mitral valve area should be 4 or more. Minimal leaflet calcification or even no calcification at all, especially in the grasping area by the clip. I will explain this later on. The coaptation length of the leaflet should be more than 2 millimeter. Coaptation length, that's we need a tissue of the leaflets to be grasped by the clip. The coaptation depth, the depth is an imaginary line between the points of the annulus and the closure of the mitral leaflet. This depth should be less than 11 millimeter. And in case of degenerative disease, what we mean by degenerative disease for MitraClip is patient with mitral valve prolapse, severe mitral regurgitation, or a flail mitral valve. So the flail gap between the leaflets should be less than 10 millimeter, because if it's more than 10 millimeters, it will not be possible to grasp both together. And flail widths should be less than 15 millimeter. Flail widths measured when the valve are closed or coapted are considered, all of these criteria are considered favorable for mitral clip. Again, all of these anatomical eligibility and anatomical criteria were got from the Everest trial. Again, very important, no mitral stenosis, no or minimal calcification. A very important point, the origin of the mitral regurgitation is central. Central means B2, A2. We described before the anatomy of the mitral valve, and we know very well that the anterior leaflet has 3 segments, A1, A2, A3, and the posterior leaflet B1, B2, B3. So the mitral regurgitation should be central through A1, A2, B2. And sufficient leaflet tissue for mechanical coaptation. As we said before, the coaptation length should be more than 2 millimeters. And this figure shows us the different anatomical criteria as regard the coaptation length, as regard the coaptation depth, as regard the flail gap and flail width, as we described before. This is the main anatomical criteria based on the Everest trial. For the procedure itself, we have to have multidisciplinary team. This multidisciplinary team consists of surgeons, interventional and non-interventional cardiologists and anesthesiologists. What is the importance of this teamwork? The importance of this teamwork, actually, it is instrumental. Number one, for patient selection, as we described before. So it's very important to select your patient for the success of this new technique. Safely perform the procedure. This team should be trained well to do this procedure, and all of this team share in doing this procedure. effectively follow up the patients after the mitral clip implants. Again, as we said before, in mitral balloon valvuloplasty, the site of puncture in the septum depends on the technique I'm going to use. In case of single balloon technique like in oil, we have to puncture the septum a little higher in the fossa ovalis, and in double balloon, I have to puncture the septum a little lower to be close to the mitral valve. So what about puncturing the septum in case of mitral valve repair? Again, puncturing the septum in case of mitral valve repair is guided by transesophageal echo. And the distance between the annular line and the puncture of the transseptal should be at least 5 millimeters. And this is very important to know and to do puncturing at least 5 millimeters from the annular plane. And this is just summary of the device and delivery system. We have a delivery system, the guiding caster or delivery caster, and we have the clip. The clip consists of arms and grippers. Between the arms and grippers, we grasp the leaflets, as we see in this figure, and it's very clear. And this figure shows how the team works together. It's very important. This team should be present to do this important technique, new technique, as we said before. This is the fluoroscopic image of advancement of the clip in the caster. As we see, after transseptal puncture and the introducer of the delivery system, we advance the clip, and the clip should go through the mitral valve while it is opened, as we see by this transesophageal echo. And this is an image, very important image, left ventricular outflow tract view. In this left ventricular outflow tract view, you have to check for perpendicularity of the mitral clip. And in this view, the mitral clip appeared opened. In the other view, which is a two-chamber view, you have to check again for the mitral clip, and in this view, the clip should appear as a closed line. So this is very important to have these two views while advancing the clip into the left ventricle. And this is the 3D echo image. The first one on the left shows incorrect commissural position of the open clip. It is not central, it is eccentric. So you have to position it in a central position. And the other one on the right is a 3D image of correct central orientation of the open clip. And this is the X-ray vision of the clip delivery system as we see it in the angiography and in the CAS lab. And again, these figures show the arms of the clip, the grippers that grasp the leaflets. In this figure, the grippers are lowered to grasp the leaflets. This is on the left, and on the right, we see that the leaflets are grasped now between the grippers and the arms of the clip. And after that, you sutured this clip in the leaflets, converting this single orifice into a double orifice like Alfieri technique. And this is a double orifice mitral valve repair anatomy. We see this just figure to show how the mitral valve shape changed after this mitral repair using mitral clip. It's very important to go through the randomized controlled trials and the randomized controlled data we have about this important new technique, which is a mitral valve repair using clip. We have the very famous trial, which is the Everest 2 randomized trials. I will not go through the inclusion criteria because we mentioned this inclusion criteria. It is it's clinical criteria and anatomical criteria. We mentioned this before, and this trial was a randomization trial, included 279 patients that randomized to either a mitral clip or surgery. Patients with mitral clip, either those who had the mitral clip implanted and they don't require any surgery, or those who have some complications that require surgical intervention, and the other part of this mitral clip group that no clip was done or no clip was implanted, unsuccessful procedure, and either patients required surgery or kept on medical or guideline directed medical therapy. And the other arm includes surgical patients. These surgical patients was 95 patients also that were randomized to either repair or replacement. What about the learning curve based on this average trial? If we see this improved MitraClip implant rate, the implant or the success rate in 2003 was 90%. The success rate in 2010 was 98%. So, overcoming this learning curve, the success rate increased over time. And this is what we call single leaflet device attachment. You know, this device should be attached to both leaflets, but sometimes we fail to grasp both leaflets and we apply this clip to one leaflet, and this single leaflet device attachment in 2003 happened in 8% of the patients, and in 2010 in less than 1% of the patient. Again, this is based on the learning curve. And what about the study results? This is the sub-analysis of different groups as regard sex, age. Mitral regurgitation is a functional degenerative left ventricular ejection fraction. And they found that the best group of this subgroup analysis are those who are 70 years or older as regards the age, those who have functional mitral regurgitation over those who have degenerative mitral regurgitation, and those who have an ejection fraction of less than 60%. This subgroup of patients did exactly the same like surgery, and there was no difference between both groups as regards this sub-analysis. When they followed up these patients as regard left ventricular volumes, left ventricular end-diastolic and in-systolic volume, they showed that there is a reduction in end-diastolic volume and in-systolic volume with improvement in the ejection fraction over time after this repair. And again, a very important point as regard repeated hospital admission for heart failure. This is also was significantly reduced in a patient who had the repair, and the reduction was 48%, and the difference was a highly statistically significant, and this is 1 year post-discharge. Again, the mortality-free, the freedom from mortality in the average two randomized trial, comparison between surgery and the percutaneous mitral valve repair, there was no significant difference between freedom from mortality in both groups, surgery. But freedom from mitral valve surgery, in the MitraClip, those patients required more surgical intervention as compared to those who did surgery who required reoperation later on. So patients who did surgery, the number of patients who required reoperation was much significantly less than those who did mitral valve clip repair and required surgery after that. A very important trial, which is a recent trial that is presented in the TCT in 2018, which is a COAPT trial. COAPT trial, actually, it is a cardiovascular outcome trial, which is a parallel controlled open label multi-center trial, included 614 patients with heart failure and moderate to severe. Moderate to severe means that 3/4 or severe 4/4 secondary mitral regurgitation who remain symptomatic despite maximally tolerated guideline-directed therapy. And these patients was randomized to 1:1 ratio. Those with MitraClip plus guideline-directed medical therapy included 302 patients, and the other group, only guideline-directed medical therapy, included also 312 patients. And this figure shows us the patient selection in both COAPT trial and the mitral and MitraFR trial. In patients with COAPT trial, they were having a more severe mitral regurgitation but less left ventricular remodeling. In patients with MitraFR trial, they have less severe mitral regurgitation but more left ventricular remodeling. And this was the main difference between the COAPT and MitraFR trial, that in the COAPT trial, patients were having more severe degree of mitral regurgitation, less remodeled left ventricle means that less left ventricular dilatation. So MitraFR having a more patients with left ventricular dilatation, disease refractory to medical therapy resulting in lower potential for improvement among control patients, Heart failure patients that could be attributed to valvular dysfunction over ventricular dysfunction, improved procedure efficacy, and less residual grade 3 mitral regurgitation in the COAPT trial, longer follow-up in COAPT since difference emerged beyond the 12 months in COAPT as compared to MitraFR. Also, we have to know the contraindication to MitraClip placement. This is very important points you have to know. This inability to tolerate the procedure, anticoagulation or antiplatelet agent post-procedure. If there is any contraindication to anticoagulation or the antiplatelet agents, this is one of the contraindication to MitraClip. If the patients have an active endocarditis, mitral valve endocarditis, rheumatic mitral valve disease is considered, till now, is considered a contraindication to mitral clip repair. Mitral stenosis from any cause, and if we go back, we mentioned that for patient selection, they shouldn't have any form of mitral stenosis, and the mitral valve area should be 4 square centimeter or more. Thrombosis of the femoral axis vein, inferior vena cava, or left-sided intracardiac structure. What about the complications of the MitraClip? The complication of MitraClip, like any complications of the casters and complications related to the clip itself. For example, axis side bleeding. This is a common complications that can happen during any catheterization. What is specific is a clip detachment from a single leaflet or device embolization and development of mitral stenosis if we overcorrect this using multiple clips. On the first large-scale trial evaluating mitral clip use, the Everest 2 clinical trial, major adverse events of death and major stroke were similar in patients receiving mitral clip and those underwent mitral valve surgery. On one hand, patients undergoing surgery needed more blood transfusion and longer mechanical ventilation, whereas mitral clip implantation was associated with greater onset of new atrial fibrillation and acute renal failure due to contrast use. Other complication rate of 30-day complications is usually in the range of 15 to 19% following such transcatheter mitral valve repair. Bleeding or partial clip detachment or clip embolization and endocarditis, all of these considered the complications that happen 30 days after this repair. The conclusion as regards the mitral clip is that percutaneous transcatheter valve repair has especially become increasingly feasible. As we said, the learning curve, the number of patients using this technique are increasing with remarkable safety profile and broadening clinical applications. While surgery remains the gold standard or the treatment of choice in degenerative mitral regurgitation, now we have the COAPT trial that has greatly enhanced our knowledge in intervention in functional mitral regurgitation. These data come as a relief after years of no clear direction, timing of mitral valve intervention, and the role for percutaneous repair in patients with chronic severe functional mitral regurgitation. What about the emerging technologies for percutaneous mitral valve intervention? We mentioned mitral repair using clip or mitral clip. Now it is one of the techniques established all over the world. Other technologies, in addition to edge-to-edge clip based on Alfieri type repair, we have some advancement and some development in the mitral clip itself, and we have the Pascal transcatheter mitral valve repair system. This is also a new device used to repair the mitral valve in case of functional severe mitral regurgitation. Second emerging technologies is percutaneous mitral valve annuloplasty, either indirectly via the coronary sinus or directly from retrograde left ventricular axis through the aorta to the left ventricle and to do this annuloplasty. Chordal replacement, but chordal replacement should be done through some surgical intervention. And the fourth, and I will go through this, a transcatheter mitral valve replacement using Sapien XT or cardiac or Caisson valve. All of these valves can be used for transcatheter mitral valve replacement. This is the development that happened in the MitraClip, and this in 2018, the third generation of MitraClip NTR and XTR system were introduced. And the use of new generation MitraClip NTR and XTR system enables more precise treatment of different anatomic situations. The difference between NTR and XTR that XTR longer arms for easier grasping of the leaflets, and I will show you the difference between. So, for example, when to use the XTR and when to use the NTR. XTR is preferred in patients with more severe mitral regurg, marked left ventricular remodeling and larger left ventricles, larger valve annular dimensions, and primary mitral regurg, flail and prolapse, large flare and prolapsed gaps, because XTR has longer arms than the NTR. And the NTR is preferred in patients with secondary mitral regurgitation and in patients with smaller valve annulus dimension. So this is the main use of XTR and NTR. Again, to conclude all of these technologies as regard mitral valve repair, that the MitraClip is the only percutaneous technology effective in post-functional and degenerative mitral regurgitation. And by degenerative mitral regurgitation, we mean mitral valve prolapse or flail mitral valve. The procedure is performed via a venous route, and the device is removable and repositionable. These important attributes contribute to the safety of this procedure. Of note, in spite of the fact that the degree of reduction in mitral regurgitation is lower than that of surgery, the clinical benefits with respect to left ventricular remodeling was observed to be similar to the surgical group. As we saw in the Everest trial, there was a reduction in both left ventricular insystolic volume and left ventricular diastolic volume, and improvement in the ejection fraction, and the hospital admission was significantly reduced in patients who had this mitral clip repair, and was the same exactly as those who had a surgical mitral valve repair or replacement. Mitral clip percutaneous repair is a safe and effective technique that will be particularly applicable to high surgical risk patients or patients who are prohibitive or declined by surgeons, or younger patients seeking a less invasive approach. So what about the second important new technology, which is a transcatheter mitral valve replacement? Transcatheter mitral valve, why we have to have this mitral valve replacement in a patient with severe mitral regurgitation? It's very important to know that in degenerative mitral regurgitation, there is something physically wrong with the valve that makes repair inefficient in this form of patient with degenerative mitral regurgitation. This is what we call primary mitral regurgitation. Also, the use of mitral clip in degenerative mitral regurgitation may limit future ability to place percutaneous replacement valve, complicating the choice of therapy. Therefore, percutaneous replacement may become viable option earlier in degenerative mitral regurgitation patients. So we can keep this mitral repair for those who have functional mitral regurgitation, or some patients with mitral valve prolapse or flail valve, and the mitral valve replacement should be for those who have other form of degenerative mitral regurgitation. The valves we used for the transcatheter or percutaneous mitral valve replacement, actually we have many, but the famous one is the Sapien XT, the Melody valve, and this valve have shown excellent success in percutaneous valve in valve and valve in ring implantation in the mitral position, but are not recommended in native regurgitant mitral valve disease. Placement of bioprosthetic valve through a vascular access has been challenging, primarily due to the device is larger than that of the TAVI procedure. An asymmetric D-shaped dynamic annulus. Now we knew the anatomy of the mitral valve, and we know the saddle shape or the D shape of the annulus. This asymmetric D-shaped dynamic annulus make placement of the valve somewhat difficult. Lack of adequate support from the native mitral valve annulus. And it's very important for transcatheter mitral valve replacement that we have to have 4 separate vascular axes, 2 in the femoral artery and 2 in the femoral vein to facilitate the complex procedure using multiple catheters and delivery system. So this is the main difference between transcatheter valve-in-valve through the transapical approach and the transseptal approach. So what's the advantages of the transseptal approach over the transapical approach? Actually, with the transseptal approach, we have a small puncture in the femoral vein to introduce the catheter, the valve, and potentially the ring if we need it. Interatrial septum puncture to reach the mitral valve. No heart muscle perforation to reach the valve, and immediate recovery for the patient. For the transapical transmitral valve replacement approach, we have to have surgical incision in the intercostal space, left ventricular perforation and puncturing to reach and to place the mitral, to reach the valve. Open heart surgery may be needed. Left ventricular wall and muscle weakening and can lead to rest disturbance. And this is valve in ring concept in patients. That's why we use both the ring and the valve for the replacement. The ring, we put it this, what we call direct annuloplasty. We put this ring through the transfemoral approach, through the femoral artery, retrograde through the aorta to the left ventricle, and then you put the ring, and you put the valve through the femoral vein to right atrium, to the left atrium through transeptal puncture, to the left ventricle while the ring in place. In this condition is what we call valve in ring concept. And again, this figure or this slide shows the steps of this valve and ring concept. First, we have to introduce the ring, and this ring is introduced retrogradely through the femoral artery to the aorta to the left ventricle, positioned across the annulus, and the valve is introduced through the femoral vein to the right atrium, to the left atrium through transeptal puncture, then to the left ventricle, introduced to the ring and placed or deployed in the ring. And again, this figure shows how to put this direct ring angioplasty in addition to the deployment of the valve delivery catheter position as we see in these figures. A very important point you have to know that if the valve is positioned incorrectly, and this may lead to left ventricular outflow tract obstruction. Looking at the figure on the left, this is the proper positioning of the mitral valve. It's away from the left ventricular outflow tract. And if we look at the figure on the right, this valve is encroaching over the left ventricular outflow tract, leading to left ventricular outflow tract obstruction. So the first one on the left is the correct position, and the second one on the right is incorrect position. To conclude, the current results of the edge-to-edge technique suggest that it may be useful in selected high-risk patients, definitely, or even patients who are prohibitive surgically or declined by surgeons. Long-term follow-up and randomized control trials in secondary mitral regurgitation are still needed. The results with coronary sinus annuloplasty, which is indirect annuloplasty, are still disappointing. Preliminary data on transcatheter treatment after surgical failure show that it is feasible that we can do this transcatheter mitral valve replacement after degeneration of bioprosthetic valve in the mitral position. In the future, improvement is expected from the new devices aimed at reproducing surgical techniques, combination of repair techniques, and valve replacement. And this is a nice slide, a nice figure that we have to keep the well-proven. We have to keep our old techniques, but at the same time, we have to be open-minded for something new, and we have to be open-minded for these important new techniques. Thank you for attention.